Thank you, Diane, and thank you to the conference organisers for the opportunity to speak about last year's award. It is with mixed emotions that I present this, and I hope you are equally inspired by what happened and what we achieved and how we can take this forward into the future in terms of future projects, both for us locally as well as others working in secondary care. So we started off, sorry, this hasn't come out very well, but a quality improvement project aim. So quality improvement, for those, I'm not going to kind of patronise those who've done a lot more work than I have in quality improvement, but certainly one of the key aims when we started this project was to undertake a quality improvement in antimicrobial stewardship, and we recognised that an issue with timely treatment of patients with sepsis was an issue. At the time, in 2013 or 14, when we first started discussing the problem, we only had 40% of our patients receiving a stat dose of their antibiotic within an hour. So our aim, quite ambitious maybe, was to target 80% within sort of the next year or two. We didn't set a specific time frame initially, but we did want to do it in a reasonably short time frame to try and achieve that target. Knowing that we had about 75 patients a day across Heartland, Solihull and Good Hope hospitals. And as a quality improvement project, it meets all the key areas in terms of quality improvement. As I said, quality improvement is about improving patients' outcome and experience through safe, effective, efficient, timely and person-centred care. And so in that respect, this project met those criteria. We focus on stat doses because there's widely known and reported that the incidence of mortality and morbidity increases over any delay with antibiotic administration. I know there's been a lot of debate recently about whether that is, whether this data is still accurate or true, but I think widely we all believe that getting treatment to patients who are poorly and unwell is important, and getting it in a timely fashion is also very critical for patients. We had an antibiotic safety team, and this was a multidisciplinary team. It involved both myself and my colleagues as antimicrobial pharmacists. We had members of the patient safety team, a consultant microbiologist, Dr. Das Pillay, corporate nurse, and importantly, ICT developer support. And the strength of this team was that we were diverse, that we had strengths in all our different areas, and Dr. Pillay was leading us in a way that he does, in terms of he didn't see barriers between professions or people, and he was a collaborator, and he wanted people to share and work together, and that certainly was one of the strengths of the team that led us to achieve what we did. So the first thing that we, as part of the project, what we tried to do was to engage with staff. I'm sorry, some of the information on here is maybe difficult to read, but I'll go through them. A series of communications bulletins went out informing staff of the issue that we had patients every day who were not receiving their stat dose of antibiotic in a timely fashion, and what that consequently may lead to patient in terms of patient harm. Lessons of the month was something that we didn't have at the time, but this was the first one that we did around antibiotic administration for patients with sepsis. There were articles in sort of the local newspapers, as well as, quite importantly, we did lots of pilot ward feedback, and we visited each ward, and we gave them a letter for every person that we visited on the shop floor to say, or to explain the importance of giving antibiotics in a timely fashion. This was a personalised letter. It may be seen as a bit of a gimmick, but actually people did value and did feel appreciated the fact that they took time out of their own daily duties to be kind of informed about the issues around antibiotic stewardship, as well as following local guidelines, as well as giving antibiotics in a prompt manner for patients who have sepsis. And lastly, we reviewed the EP, our electronic prescribing codes for non-administration. We realised that lots of nursing staff were giving inappropriate reasons for, or not selecting the right reason for a missed dose. And in order for us to drive improvement, it was important that we had accurate data. So what we did was we went and engaged with all the ward staff and asked them to tell us what reasons for non-administration they wanted to have, which weren't on there, and which ones they weren't using, to try and rationalise the list of non-administration codes so that they were choosing the correct one when they came to select a non-administration reason. So altogether, all of this was, formed part of our engagement with staff, and through that we identified a number of barriers, and key to us having success in this quality improvement project was having a person-centred approach, which means we were talking both to staff and to patients to understand why it was that patients were having delays in their antibiotic treatment. For example, there were delays due to IV competence and cannulation skills, and so we provided junior doctor training on cannulation, and now that is now part of routine junior doctor induction. Surprisingly, some of the consultants were the consultants were quite surprised that junior doctors don't give IV antibiotics anymore on the wards, because when they were housemen, they were working on the wards, they would administer stat doses themselves and make up the antibiotic and give it to the patient if they needed it. But certainly the current practice was that junior doctors would prescribe a stat dose and leave it to the nurse to administer. So we provided training, and this is all part of routine induction training now. There were a number of junior doctor prescription queries, doctors not, maybe communicating very well. So we ensured that we initially developed our own smartphone app, which was called eTag, which then was superseded by MicroGuide, which is now used by a lot of trusts for doctors to refer to for their antibiotic guidelines. We also reinforced the fact that they need to communicate to nursing staff if there are patients that are poorly that need an urgent antibiotic dose. There were issues around Wi-Fi connectivity, and those were resolved. There were omissions due to prescription queries and anxiety around double dosing. So what we were finding were patients were being prescribed a stat dose of an antibiotic, and the next dose, which may have been due 2 or 3 hours later, was either missed, or the nursing staff were choosing themselves to not give the stat dose because they knew another dose would be due in a few hours. So what we did was to clarify that, and I know it may not be recommended in product literature for any of the antibiotics, but we gave some guidance around when they could give the next dose following a stat dose. And lastly, we launched a dashboard showing performance based on the dosing and administration of stat doses. So through staff engagement and continued improvement, so we went from about 40% through to of stat doses being given within 1 hour to about 60%. And what really drove through the improvement was an innovation that came about through staff feedback and further collaboration and work with the electronic prescribing team as well as ICT. And that was to link in the signal from the electronic prescribing system to the Blick pager system, which is used by many trusts, or pretty much all trusts, I think, and a software integration system that allowed that dose, when it was prescribed in an electronic prescribing system, to alert on a bleep. Again, as with all quality improvement, there were PDSA cycles, so we did it initially and found that we were alerting people straight away, and nursing staff regretted the fact that they didn't have that conversation communication with the doctor. So what we then did, and what we still do now, is that we allow a 15-minute period where nursing staff and doctors can communicate, and we're still encouraging good communication between the doctors and nursing staff, so that they speak to the nurse and tell them that their stat dose is due, or either that or they administer it themselves. And if a dose isn't given within 15 minutes, the bleep then goes off and continues going off every 15 minutes until the dose is administered. So in cases where that bleep does go off, the nurse can then log into the real-time dashboard showing each and every stat dose that's prescribed on that ward, giving them information around patient as well as what antibiotic they're prescribed. As I said, this doesn't negate the need for a doctor to speak to nursing staff about what the treatment plan is for the patient, but what this did was certainly help push through the improvement. And so we trialled it in acute admission, which was our worst performing area, and before we introduced the bleep, they were 68%. As I said, they were doing much better than they had done ever before, because they were usually around 40% of doses being given within 1 hour. And they achieved 90% at Solihull and 76% at the Heartlands Hospital site. So we were encouraged and continued and rolled that out across the trust. And so this dashboard shows the overall trust and site compliance, and this dashboard was then being used by nursing ward managers, matrons, directorate leads across the trust to monitor and see how the trust was performing, because everyone was then taking an interest now in how we are doing in terms of stat dose of antibiotics being administered. This screenshot was taken 2 weeks ago, a week or two ago. You can see at the end it's 20th of June, and we were still now performing at above 80%, around 81%. So this improvement has been sustained over the last 2 years, and our challenge now is to prove that further and maybe refine who we are targeting in terms of these treatments, because not all patients who have a stat dose are necessarily septic. So going forward, we're obviously, you may be aware the sequence requires us to use a new deteriorating patient score called NEWS2, and if we can incorporate that in an electronic manner and capture that together with the stat dose being prescribed, would be more specific. We produced a number of educational resources as we went round the wards. We looked at improving the ordering process for making sure that antibiotics were available on the ward. We introduced a bleep holders guide, which explained to the nurse coordinator, the ward who's working on the ward, what they needed to do and how they needed to respond. An SOP was developed around administration of stat doses and when it was appropriate and when it wasn't appropriate to delay the next dose, because we were finding nursing staff were staggering the next dose after the first. And a series of videos were produced. We kind of became quite good at making videos. So we made a couple of videos, and they were really successful in terms of engaging staff, incorporating them in induction for nursing staff, doctors, healthcare assistants, porters. Involved everyone, because we recognise everyone working with medicines had a role to play in terms of antibiotic administration. So altogether, what was the key to our success? From the right-hand side, we used improvement methodology, using plan, study, do, act, and refining as we went along. We produced a number of education resources. There were organisational barriers, such as doctors not being able to cannulate and administer stat doses, so we provided that training. We still do consult with staff on the ward as well as ward managers about what we can do to try and improve and sustain that improvement. We had good support across all the multidisciplinary team, and we gave the ward staff the power to sort of dictate how and where we moved forward. So they shaped much of what happened through the project. And so that is where we are now. So we can see that over the last 4 years, we have steadily seen an improvement. The total number of stat doses has gone up, and I can only explain that by the fact that our activity and our acuity of patients that we see is much more than it was before. And the challenge we now have is with late doses being not having improved. We've seen a massive improvement with non-administration of doses. You can see from 30% to 7%. But the challenge now is to try and address the issue around the late administration of doses. And there are challenges ahead with that as well, with as mentioned, we are getting busier, as all hospitals are, and finding the resources and the time to make sure patients that are poorly are treated effectively and in a prompt manner is going to be a challenge. And I guess part of that, as I alluded to earlier, is targeting it to patients that are genuinely unwell and septic, as opposed to patients that giving a stat dose may not indicate whether the patient's poorly or not. That's a surrogate marker. What we could do with is a more accurate measure of how poorly a patient is, and so that we can maybe target treatment to those effectively. So we've seen a real and sustained improvement. We've seen collateral effects on antibiotic stewardship in terms of doctors using guidelines properly and seeing an improvement in terms of appropriateness of antibiotic usage. And we've used the bleep for other time-critical medicines. Lastly, just want to pay tribute to Dr. Das Pillay. He was a dear friend, a mentor, someone who I looked up to. He inspired me. He was here last year, and my memories are still very, very fond of him in terms of what we achieved on that night, and certainly the Antibiotic Guardian awards and conference has grown year on year. It's much bigger and better than it was last year, and all credit goes to Diane and for all of us and everyone else for organising this event. But certainly Dr. Das Pillay was a big believer in the Antibiotic Guardian movement and the fact that we have this opportunity to collaborate, to share, to confront the challenges together and work together. And I am also very grateful for Dan and the organisers to have the award that we now have in his memory, the Das Pillay Antimicrobial Stewardship Award, which recognises junior members of staff, nursing, medics, in terms of their involvement in antibiotic stewardship, and I believe and I wish it every success in the future. We did have a Twitter handle for, I don't know, I'm not very good with Twitter, I don't know if it's a handle or a hashtag, sorry, but a hashtag for Do It For Das, and this year we had a lot of people who, as part of our antibiotic stewardship program, we and during our World Antibiotic Awareness Week, it was quite successful. So thank you, Diane, and thank you to everyone for your patience.